Usually when we talk about a medical diagnosis, there's this expectation of absolute precision.
Right, like it's engineering or something.
Exactly. I mean, you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is.
Yeah.
The problem is visible, it's categorized, and you just move straight to the fix.
It's a very comforting binary, you know? The bone is broken or it isn't, the test is positive or it's negative.
Right.
We are just wired to prefer problems that present themselves clearly on a screen.
But then you step into the world of pediatric neurology.
Oh yeah, totally different ballgame.
Specifically, diagnosing something like cerebral palsy, suddenly that metaphorical x-ray machine is broken.
Right, it's useless.
We're looking at a diagnostic landscape that is incredibly murky. Symptoms overlap, and the stakes for getting it right are massive. So today, we are pulling apart a clinical transcript that acts as a masterclass in medical problem solving.
It really is.
We're extracting the core insights on a highly structured framework for diagnosing cerebral palsy, or CP, and knowing exactly when to hunt for what clinicians call genetic mimics.
This source material is remarkable because it takes this inherently ambiguous situation, a clinician observing a child with developmental delays, and it filters it through this elegant, incredibly disciplined clinical framework.
Yeah.
It's basically all about managing uncertainty.
So what does this all mean? Like, why should you, the listener, care if you aren't a doctor?
Right.
Well, if you rely on mental models in your work, if you want to understand how true experts navigate high-stakes uncertainty, the logic we're about to explore is a literal blueprint for critical thinking.
Absolutely.
It's about diagnostic hygiene, because getting this wrong has real costs. If a doctor overtests every single child who comes in with a classic, easily explainable presentation of CP, they waste valuable medical resources.
And they cause immense unnecessary anxiety for the parents.
Right, sending them down these terrifying rabbit holes of rare genetic mutations. But on the flip side, if they undertest an atypical case because they just jump to conclusions, they might miss a potentially treatable metabolic condition.
If we connect this to the bigger picture, diagnostic hygiene is universally applicable. Whether you are debugging software, auditing a supply chain, or examining a patient.
Yeah.
Before you can solve a complex puzzle, you have to verify that you're actually looking at the puzzle you think you are.
Right, you have to know what game you're playing.
Exactly. It's about calibrating your attention, knowing when to accept the obvious, internally consistent answer, and knowing exactly when the data is screaming at you to dig deeper.
So let's get into the mechanics of this framework. Before a clinician even deploys the advanced genetic logic we're going to cover, there is a basic first move, the initial trigger, right?
The first thread to pull.
Yeah, they have to spot that something is fundamentally off. And the single most common presentation that prompts a CP workup isn't like a dramatic seizure or a sudden collapse.
No, rarely.
It's just simple developmental delay.
It usually starts with a very subtle observation. You know, a parent brings their baby into the clinic and mentions, almost as an aside, that the baby isn't rolling over yet, or they aren't reaching for toys on the schedule they expected based on their older kids. That is the initial thread. And the clinician then has to decide whether to pull that thread or just wait and see.
But the challenge is that a 4-month-old baby can't tell you what's wrong.
Right, they can't speak.
You can't ask them to describe a weakness in their left leg or a tingling in their arm. So the clinician has to search for physical clues that act as proxies for brain function.
Yes.
And the source material highlights a very specific cluster of physical tells, starting with the persistence of primitive reflexes.
Which is fascinating, because infants are born with a sort of neurological firmware package.
Firmware, I love that.
Yeah, these hardwired primitive reflexes like the grasp reflex or the rooting reflex, they're basically survival mechanisms.
Right.
But as the higher cortex of the brain develops and matures, it is supposed to actively suppress or integrate those primitive reflexes. And that is what allows the baby to make smooth, voluntary movements.
So if those primitive reflexes are still hanging around, like long past the age they should have disappeared, it means the higher brain centers aren't successfully taking control.
Exactly.
The firmware hasn't been overwritten by the software yet.
That's a great way to put it. When those reflexes fail to integrate, it is a glaring signal that the brain isn't maturing in the expected way. And since you can't ask an infant to perform complex voluntary motor tasks, you rely on the presence of these primitive reflexes as your window into their neurological development.
Along with those reflexes, the transcript details some incredibly specific visual markers. They mention increased tone, abnormal posturing, toe walking.
Yes, very common.
But two visual descriptions really jumped out at me because they paint such a vivid mechanical picture of what's going wrong. They call them cortical thumbing and scissoring. Cortical thumbing is this intense fisting of the hand where the thumb is tightly trapped inside the palm. And scissoring is when the legs rigidly cross over each other, like a pair of scissors, because the inner thigh muscles are constantly pulling them inward.
We really need to understand the mechanism behind those physical signs because they are classic manifestations of upper motor neuron injury.
Which leads to spasticity, right?
Exactly. In a healthy brain, there's a constant balance of excitatory signals telling muscles to fire and inhibitory signals telling them to relax. The brain essentially acts as a brake on muscle tone.
Okay.
But if the brain suffers an injury, those inhibitory signals, the brakes, are often damaged.
So the muscles are just constantly receiving the signal to fire. The brakes are completely off.
Precisely.
So the thumb gets clammed down into the palm, and the powerful adductor muscles in the legs just fire nonstop, crossing the legs involuntarily.
Right. When a clinician sees that thumb tucked tightly into a fisted palm or those legs crossing automatically, they are literally seeing the physical evidence of damaged communication cables from the brain to the muscles.
You know, diagnosing at this stage reminds me of reading subtle tells in a high-stakes poker game.
Oh, that's interesting.
Because the baby is holding the cards, right? They know the hand, but they can't speak. So the clinician is sitting across the table, reading the twitches, the resting position of the hand, the tension in the legs.
Right.
You're just looking for the physical tells that betray the hidden reality inside the brain.
And those physical tells are vital because they force a pivot. They move the clinician from a vague, general sense of developmental delay into a specific neurologic suspicion.
Yeah.
But spotting the tells does not give you a diagnosis of cerebral palsy. It simply tells you that you must immediately ask the most important question in the entire diagnostic process.
Which brings us to the highest yield concept in this entire deep dive. Here's where it gets really interesting. Once you spot those physical red flags, the immediate next question isn't, what exact disease is this?
No, it's not.
The question is, where is this going?
The trajectory question.
Yes. When a clinician takes a developmental history, they aren't merely making a static checklist of whether the child can sit, stand, or babble.
Right, it's not just a snapshot.
They are plotting a curve over time. They categorize the trajectory of development into one of three distinct buckets: acquisition, plateau, or regression.
And this represents the ultimate fork in the road for diagnosing cerebral palsy. We have to look at how CP is fundamentally defined.
Okay.
It is a non-progressive condition. It is caused by a static, one-time injury to the developing brain, maybe a lack of oxygen at birth or a bleed in the brain of a premature infant.
Right.
But the critical point is that the injury itself is an event that is over. It does not get worse over time.
So because the injury is static, the child's development should theoretically still be moving forward. Like, even if they are acquiring skills agonizingly slowly, they are still acquiring them.
Exactly.
Continued skill acquisition is completely consistent with CP.
The child with CP will still learn new things. They'll just do it on a delayed timeline and perhaps using altered motor patterns to compensate for their injury.
Okay, let me test an analogy here to make sure the mechanics of this are rock solid. Think about developmental trajectory like a stock market graph.
Okay, I'm with you.
If a stock is climbing incredibly slowly, maybe it's sluggish, it's underperforming the rest of the market, and it takes years to see a small return. It is still technically a bull market.
Yeah.
It is still growing.
Yeah.
That represents our child with CP who is acquiring skills slowly due to that static injury.
Yes, perfectly said.
But the second that stock chart hits a peak and starts consistently crashing day after day, losing all the value it previously built up, that is regression.
And you know instantly you're not just dealing with a sluggish market anymore.
Exactly. You are in a completely different economic reality. Regression seems to be the absolute deal breaker for a CP diagnosis.
The stock market analogy holds up perfectly here. If you see a market crash in a child's development, if they were previously able to sit up unassisted, or use a pincer grasp, or say a few words, and now they have actively lost those abilities, you are no longer dealing with a static injury from birth.
The core assumption of CP has just been violated.
Because a static scar on the brain doesn't suddenly start erasing previously learned skills months later.
Right.
Regression points a massive warning sign away from cerebral palsy and straight toward an active, ongoing process.
Like what?
Well, it suggests a neurodegenerative disease that is actively destroying brain tissue,
Yeah.
or a metabolic disorder where toxins are actively building up and poisoning the nervous system.
Wow.
Applying the core definition of CP directly at the bedside by relentlessly verifying the trajectory that is the primary defense mechanism that saves clinicians from anchoring on the wrong diagnosis.
Okay, let's unpack this next phase. Let's assume we've checked the reflexes, we've spotted the physical tells, and we've verified the trajectory.
No regression.
Right, no regression. The developmental stock is climbing, albeit slowly. At this point, the clinicians finally deploy the core of their framework. Step one is the consistency check.
Yes, and this is all about testing the internal logic of the patient's story. The clinician is actively trying to prove that the history, the physical exam, and the brain MRI all align with a recognizable, known mechanism of brain injury.
The source material gives a couple of really clear examples to illustrate this. The first involves a child presenting with spastic diplegia, which means stiffness and tightness primarily affecting the legs.
Right.
Their medical history shows they were born prematurely, and their brain MRI reveals something called periventricular leukomalacia,
Which is a very specific type of white matter damage near the fluid-filled ventricles of the brain.
Right.
What's fascinating here is the why behind that alignment. The blood vessels in a premature baby's brain are incredibly fragile, particularly in the areas right next to the ventricles.
Okay.
If there's a drop in blood pressure or oxygen, those areas are highly vulnerable to injury, resulting in that periventricular leukomalacia. Now, structurally, the specific nerve cables, the motor tracks that send signals down to the legs, happen to run right through that exact area next to the ventricles.
Oh, wow. So they're right in the line of fire.
Exactly. So prematurity leads to a specific focal injury, and that specific focal injury damages the cables going to the legs, resulting in spastic diplegia. A directly causes B, which directly causes C.
The internal consistency is just bulletproof.
Yes.
The second example they provide is a child with hemiplegia, so weakness on just one side of the body. The imaging shows clear evidence of a perinatal stroke, meaning a stroke that occurred right around the time of birth.
Again, the mechanism is entirely consistent. A stroke damages one hemisphere of the brain, which causes weakness on the opposite side of the body.
And this brings us to the most difficult part of the consistency check, right? The discipline to stop.
Yes.
If the history, exam, and MRI align perfectly, providing a clear mechanical explanation for the child's symptoms, the clinician generally stops. No further genetic workup is necessary.
It really requires restraint.
It makes me think of building a jigsaw puzzle.
Okay.
Like if you buy a puzzle and the box has a picture of a boat on it, you start putting the pieces together and they clearly form the hull and the sail of a boat.
Right.
You don't go rummaging around the house looking for pieces of a spaceship.
No, you don't.
The story makes internal sense. You have your answer.
But the temptation in modern medicine is to run every possible test simply because the technology exists.
Right. Why not just be sure?
Well, true clinical expertise is recognizing when the clinical picture is adequately explained. Running a massive genetic panel on a child who clearly just suffered a perinatal stroke introduces a high probability of finding meaningless genetic noise.
Which just terrifies the parents.
Exactly. It terrifies them and wastes resources.
But biology is messy. So what happens when you are building that boat and suddenly there's a piece of a rocket booster sitting in the middle of the table?
That changes things.
Yeah, what happens when the story refuses to line up? That forces a shift in strategy. You can't just jam the puzzle pieces together and pretend it's a boat. You move to actively hunting for things that are mimicking CP.
Right. This is the transition from confirming a static injury to actively screening for red flags, steps 2 and 3. We are looking for clues that suggest a hidden genetic or metabolic disorder masquerading as cerebral palsy.
And the transcript categorizes these red flags into 4 distinct areas: history, family, exam, and imaging.
Yes.
In terms of medical history, a glaring red flag is a child presenting with severe motor symptoms but having absolutely no documented history of a birth injury.
That's a big one.
Like, there was no prematurity, no lack of oxygen, an uncomplicated delivery, yet the child is profoundly affected. And of course, as we discussed, any history of developmental regression is an immediate red flag.
Moving to family history, clinicians look for multiple affected family members, which suggests a genetic pattern. They also ask about parental consanguinity, whether the parents are blood relatives, which significantly increases the risk of rare recessive genetic conditions surfacing.
Then we have the physical exam red flags. One that stands out is isolated hypertonia.
Floppy baby syndrome,
Yeah,
essentially.
yeah, a baby who is incredibly floppy with very low muscle tone, but they don't have a clear history of a massive brain bleed or stroke that would explain it. Another red flag is seeing prominent extrapyramidal features like rigidity or severe involuntary twisting movements.
We really need to explain why those extrapyramidal features are red flags.
Yeah, let's do that.
Those movements originate in the basal ganglia, which acts as a complex switchboard for movement control. Now, while a severe lack of oxygen at birth can sometimes damage the basal ganglia, if a child has severe rigidity or writhing movements without a catastrophic birth history to explain it,
Something else is going on.
right, it strongly suggests a metabolic issue is poisoning that switchboard from the inside out.
Okay, the final area for red flags is the MRI. If a child has severe motor deficits, but their MRI is completely 100% normal, that is a massive red flag.
Think about the implications of a normal MRI in a symptomatic child.
Right.
It means the physical hardware of the brain looks structurally intact, but the system is still failing.
It's a software problem.
Exactly. It implies a software problem, a metabolic or genetic dysfunction at the cellular level that an MRI simply can't see.
Wow.
Conversely, if the MRI shows damage that is hyper-isolated to one tiny specific structure, like just the globus pallidus, that is also highly suspicious.
Why is that?
Because a hypoxic event, a lack of oxygen, usually causes widespread damage or affects border zones between blood vessels. Hyper-isolated damage suggests a specific genetic or metabolic toxin that selectively targets that one specific type of cell.
So if a clinician goes through those 4 areas, history, family, exam, imaging, and finds 0 red flags, the presentation is explained, they stop. But if they hit a red flag, that triggers the final phase of the framework. Step 3, targeted genetic testing.
Yes.
Now wait. Based on what we've read, we live in an era where sequencing the entire human genome is accessible, so I have to push back here. If a doctor hits a red flag, why wouldn't they just order a massive blanket genetic panel?
That's a fair question.
Like, why do all this targeted detective work if a machine can just scan 20,000 genes at once?
It is the most common pitfall for modern clinicians. Ordering a blanket panel without a specific hypothesis yields a massive amount of information overload. When you sequence thousands of genes aimlessly, you frequently uncover what geneticists call variants of uncertain significance.
Meaning a mutation exists, but science has no idea if it actually causes a disease or if it's just a harmless quirk that makes someone unique.
Precisely. Handing parents a report filled with variants of uncertain significance creates an agonizing limbo.
I can't even imagine.
They know something is genetically different, but nobody can tell them if it's responsible for their child's condition. To avoid this, the framework dictates using the patient's specific movement phenotype, the exact type of physical symptoms they have, to guide and narrow the testing before blood is ever drawn.
And the transcript details 3 main pathways for this targeted testing, and the underlying logic for each is just fascinating.
It really is.
The first pathway. If the child presents with a spastic picture, that rigid stiffness and tightness we talked about, and they have red flags, the clinician targets the genetic testing towards structural issues, like hereditary spastic paraplegias or leukodystrophies.
The why here is crucial.
Yeah.
Spasticity, as we discussed, is generally caused by damage to the upper motor neurons, the communication cables running down from the cortex. Leukodystrophies are genetic disorders that specifically attack the myelin, the protective insulation wrapped around those cables. If the insulation breaks down, the cables short circuit, the inhibitory signals fail, and you get spasticity. So a spastic phenotype points directly toward a structural cable problem.
Makes total sense. The second pathway focuses on a dyskinetic picture. If the child has involuntary twisting, writhing movements, the clinician targets the testing away from the cables and toward neurotransmitter disorders or organic acidemias.
And again, the mechanism explains the target. Dyskinetic movements involve the basal ganglia. That switchboard we mentioned relies heavily on a delicate balance of chemical neurotransmitters like dopamine, and it has an incredibly high energy demand.
Right.
If a genetic metabolic disorder disrupts the production of those chemicals or causes toxic acids to build up and choke the energy supply, the switchboard misfires wildly. causing those writhing movements.
Wow.
And crucially, some of these metabolic and neurotransmitter disorders are actually treatable if caught early, sometimes with just specific vitamin cofactors or dietary changes. Missing a dyskinetic mimic is devastating because you might be missing a reversible condition.
That is heavy. Okay, the third and final pathway. If the child presents with an ataxic hypotonic picture, meaning they are floppy, deeply uncoordinated, and lack balance, the clinician targets the genetic testing towards cerebellar malformation syndromes or mitochondrial disorders.
Because the cerebellum is the brain's coordination center. If it doesn't form correctly due to a genetic malformation, you get profound ataxia and lack of balance.
Okay.
Furthermore, the cerebellum and the muscles themselves require massive amounts of energy. Mitochondrial disorders impair the cell's ability to generate power.
Right, the powerhouse of the cell.
Exactly.
Right.
When the power grid fails, the high-demand coordination centers fail first, leading to that floppy, uncoordinated presentation. You're using the physical reality of the child's body to aim the genetic testing with absolute precision.
And the expert in the source material offers a vital piece of advice for anyone learning this process. They explicitly say, do not try to memorize every exact gene name and every ultra-rare syndrome under each of these three pathways.
It's an impossible task, and honestly, it misses the point of clinical mastery.
Right.
The advice is to internalize the transferable framework. Understand the three-step logic. Memorize the broad mechanistic associations. Spastic points to structural cables. Dyskinetic points to metabolic chemistry. Ataxic points to cerebellar energy.
Yeah.
Treat the specific named syndromes as reference material. When you have a complex case that fits a phenotype, you just look up the specific genes, usually in consultation with a neurogenetic specialist. The framework itself is the actual skill. The specific names are just data points you plug in.
It is a masterclass in cognitive offloading. You treat specific data as an external hard drive, while your brain focuses entirely on running the operating system, the transferable skill of clinical reasoning.
Yes.
So let's recap the elegance of this entire flow. You observe developmental delay. First, verify the trajectory. Acquisition keeps you on the CP path. Regression is an absolute deal breaker.
Perfect.
Step 1, check internal consistency. Do the history, exam, and MRI form a logical picture? If yes, stop. Step 2, if the picture doesn't make sense, hunt for red flags in the history, family, exam, and MRI.
Right.
And step 3, if there are red flags, use the specific movement phenotype to dictate your targeted genetic testing.
This raises an important question, though, because this framework is essentially a mental model for defending yourself against cognitive bias.
Yeah.
In any profession where you are inundated with complex data, it is incredibly easy to fall in love with your first theory and just force the data to fit.
Confirmation bias.
Exactly. This structured approach forces you to continuously pause and ask, does this narrative actually survive contact with the underlying mechanics? It prevents diagnostic momentum from carrying you off a cliff.
You have to prove the puzzle pieces actually fit rather than just jamming them together because you want the satisfaction of finishing the puzzle.
Precisely.
And that leaves me with a final thought for you to ponder today. This source material brilliantly emphasizes treating specific named syndromes and genetic mutations as reference material you simply look up, right? While the human clinician's true value lies in holding and executing the logical framework.
Right, the operating system.
Yeah. But as artificial intelligence becomes deeply integrated into medical diagnostics, an AI capable of holding every single gene, every rare phenotype, and every metabolic pathway in its active memory simultaneously, while instantly executing this exact three-step logic without bias, will the human role shift entirely?
Oh, that's a profound thought.
Like, if the machine eventually handles the diagnostic framework and the data recall flawlessly, perhaps the true future of clinical expertise won't be about cognitive frameworks at all.
It changes everything.
Maybe the future of being a doctor will be purely about empathetic communication, navigating complex human values, and just holding a parent's hand at the bedside when the machine delivers the answer.
It requires a profound shift in how we view expertise. If the framework gets automated, humanity becomes the ultimate specialty.
Thank you for joining us on this deep dive. Keep examining the complex puzzles in front of you, keep looking for the red flags in the data, and above all, keep questioning the information around you. Until next time.